If you're ready to unlock more better days, to take control of your health, to push past your limits and unleash your full potential, then you're in the right place. I'm your host, Dr. Jeremy Bettle. For over 2 decades, I've worked with elite athletes and high performers, helping them optimize their bodies, strengthen their minds, and recover from setbacks. Now I'm bringing that expertise to you through the Vitality Collective podcast. In each episode, we'll dive deep into the science, strategies, and real-world solutions you can apply right away. Whether it's enhancing your physical performance, avoiding or recovering from injury, sharpening your mental edge, or simply feeling your best every single day. With insights from top experts and thought leaders, this podcast is designed to help you take action, feel better, and live the life that you deserve. Welcome to the Vitality Collective podcast, where every day is vital. Today, I'm joined by Dr. Kelly Casperson, a leading urologist and expert in women's health and thriving in midlife. In this episode, we dive into the realities of perimenopause and menopause, why hormones have been misunderstood for decades, and how women can advocate for themselves within the healthcare system. If you've ever wondered why so many women struggle to get the right answers about hormones, or if you want to know how to age with strength and vitality, this conversation is for you. Let's get started. Dr. Kelly Casperson, welcome to the show.
Oh, Jeremy, my honor to be here. Thanks for having me.
The honor's ours. Thank you so much. Well, I want to dive right in because we got so many questions from our post, one quick reel with you here in Santa Barbara, and we got inundated.
Did you expect that? Were you like, I hope somebody writes a question?
That's
and then
the initial
you're
thought,
like lists of questions.
Like emails with lists of questions. It wasn't enough just to be on social. So
they like prioritize them. They're like, question number 2 is more important than question 5. Here's the order of questions. Yeah. People are hungry. They're hungry for good information. They're hungry for it.
Well, and that's one of the reasons that I wanted Vitality Collective to focus in on women's health, because since Michelle and I got married, she had a hysterectomy before we actually met. And so I have watched and learned a lot through watching her navigate the healthcare system and the challenges with having somebody proactively manage her hormones has been really difficult to watch. And I've really started to realize and why women live longer with a female physician. Has been really apparent watching Michelle navigate this. I'm so grateful for your work and grateful to have you.
Thank you.
And where I would like to start, I have a PhD in human performance, and this might surprise you. We didn't go through the female reproductive cycle a whole lot in grad school.
Well, I mean, it just goes to show you that in teaching, male is the default.
Yeah.
Right. Like male's the default, and you're like, dude, there's 50% of the other humans, right? Like it's a big amount of other humans. And to completely negate what happens in their bodies to the point where like they think that what they're experiencing is not normal. It's a big problem. We're going to spend our careers digging out of the hole that is the current system and how we're treating women.
Yeah. So the collective here listening are sort of 50-50 split male and female, but I'm not sure if education has really caught up on either side. What exactly at a high level is going on during the female reproductive cycle?
Yeah. So just to back up for people, I am a urologist. I'm not a gynecologist, but I do assume I know it a little bit better than somebody who didn't go to med school. So I'll try my best. But roughly monthly, 28 days is like the stereotypical, but nobody's stereotypical there is an ovary. Ovary is 2 separate structures, just like the testicles, right? So testicles make sperm and testosterone. Ovaries make hormones, including testosterone, estrogen, progesterone, and eggs, right? So those are the 2 structures. Female ovaries are in the pelvis, so you can't see them, whereas testicles are more in the scrotum. You can check them out. And what they do every month is they prepare a follicle, and a follicle is kind of like a tent. And in that tent is an egg, right? So you've got hundreds and thousands of follicles you're born with, and they age as you age. And roughly every month, some follicles compete to be the winning follicle, and then the follicle, the tent, gets to release an egg. And in that follicle, in the tent, is also all of these hormone producing cells, right? So we're producing a big estrogen surge when we release or we ovulate. So a follicle wins, an egg goes out. The egg's going to hang out for a while in hopes, or its job is to get fertilized and create another life. The freaking miracle that this body is, right? It's like they can create life. You'd think we'd be more interested in that. It's fascinating. So egg releases, estrogen goes up, testosterone goes up at the exact same time. So estrogen and testosterone go up. That's called mid-cycle, because they call your day of period is day one of the cycle, because it's a lot easier to know when that day is, right? Than your ovulation day. So ovulation day is mid-cycle, about day 14, and estrogen starts to go down. By the end of the cycle, the progesterone's going up because the progesterone prepares the uterus for implantation. It makes a very hospitable lawn to put the egg on. And so the egg goes near, and if it gets a sperm, then it's going to fertilize into the lawn. And if not, then the progesterone's going to go down. You're going to shed. That's a period. And then it starts all over again. So that goes on from, it's a rocky start in puberty, right? People don't just, turn 13 and start having regular periods. So off and on, light, you might have a period without ovulating. We call it kind of the roller coaster of the on-ramp. Then you have a couple of decades where there might be some pregnancies in there. There might be some birth control in there. But by and large, you're going to cycle from teenage years to mid 40s, roughly. Then menopause is, in America, average age 51. Average means average, which means half is before that, half is after that. Right. So I had talked to a woman this week, and she's like, my doctor says I'm too young because I'm 45. And I'm like, no. Menopause is like 45 to 55 is kind of like that bell curve, but before 40 is considered early.
Right.
In other words, premature. Not people don't like that word. So you can still have periods, but still not have exceptional egg quality, right? So that's where you get the women in their 40s. Like, I'm still having periods, but it's a lot harder to get pregnant, right? The egg quality isn't as good. And so that's also good to know, because people will think another big myth is that you can't start hormones until your periods end, which is stupid and made up and wrong. And also 1/3 of women in America have an IUD, or they've had an ablation, or they've had a hysterectomy. So they don't have periods to tell them when their menopause is. The definition of menopause is an old definition. Back when we didn't have tests, back when we didn't have uteruses that came out in surgery, right? So back in like the 1800s, a physician said menopause is 1 year with no natural periods. That's a crappy definition for a couple of reasons. Number one, 1/3 of women don't have periods, right? Like surgery, ablation, birth control, IUDs, whatever. So like, how do they don't fit the definition of menopause, right? And the other problem with the definition of menopause is no periods is actually just a symptom of lack of hormones. Right. So saying menopause and that using that definition doesn't actually tell you this is a profound state of hormone change, just like pregnancy is, just like postpartum is, just like puberty is, right? Because people are like, this is so unique and weird. It's like, women have profound hormone changes multiple times in their life. Let's normalize bodies. But if women, humans, just think menopause is a hot flash and no periods, then they're completely shocked when they're like, I'm gaining weight in the middle, I'm moody, I'm not sleeping right, it hurts with sex, I have to pee way more. And you're like, that's all of the low hormone stuff profoundly affecting your body. So I don't like the term menopause, because it's kind of made up and old and doesn't explain things and doesn't fit everybody. But that was a very long answer to your menstrual cycle question, Jeremy.
No, it's perfect, because I think what it does is it shows us how we're thinking about this. Is you've got this period up until menopause, then there's menopause, and there's no transition in between.
Right. I mean, because the definition is the day after 1 year, right? So like, if you want to be very technical, menopause is 1 day. And then technically you're post-menopause after that 367th day of no natural periods. But the general term people call a 70-year-old, they'll say she's in menopause, whether she's post or in it. Like, who cares? We know what you mean.
Yeah.
Yep.
So you've given us that time frame of up to, around 45. And one of the things that I thought was fascinating, of the many fascinating parts of your documentary that you featured in
Thank
M
you for
Factor,
watching that.
it was phenomenal.
M Factor on PBS for anybody who wants to check that
Yeah.
out.
And yeah, we'll just have a little caveat onto that. We can only cover so much in an hour. And so please, men, women, everybody, go and watch that. It's so important. Um, but one of the things that stood out was often with the perimenopause period, people only realize they're going through it once they're through it.
Yep.
And they look back and in retrospect, they're like, oh, now that makes sense. So as we go into perimenopause, what are some of the symptoms that women might experience? And when do you think for most women that would start?
Yeah, so perimenopause is peri means a surrounding or around for people who want to
Right.
know. So perimenopause technically means the years around menopause, but most people mean the years before menopause. It can start in your 30s. Certainly late 30s
Mm,
is not crazy, especially if you're going to, who knows, maybe you're going to go into menopause at 45. All right, well 10 years before that's 35. The biggest two big problems with perimenopause, number one, there's no blood test for it. Will
mhm,
they at some point have an ovarian function blood test that will give you a cutoff for perimenopause? Probably. We just don't have that now.
mhm.
And why is that important? Because testing something and seeing it kind of makes it real. And the
Mhm.
fact that we don't have that makes it very not real for people. Like the amount of women who've said, my doctors don't believe in perimenopause. And it's like, do they believe in puberty? Like, it's
Right.
just the opposite of it,
Yeah.
right? And
Right.
so just like, so many people with menopause, they're like, you have periods and then you don't. Like, it's this big binary thing. And it's like,
Right.
well, you don't turn 12 and then you're a 25-year-old with normal cycling periods, right? Like you have
Right.
years of physical development that's
Mhm.
happening because the hormone functioning organs are like ramping it up, right? And so
Mhm.
really that's what perimenopause is it's the ovaries saying, all right, it's a little harder to work. I'll work today, maybe not next month. And it's kind of that sputtering. Some people call it the roller
Yeah.
coaster. Some people call it reverse puberty. And so the first thing I want women to know is it's real. It's
Yeah.
as much as puberty is real, perimenopause is real. But, do we look at a 14-year-old and be like, I don't know if this is puberty or not? We don't have a test for it. Right?
Right.
Like, no, it'd be a ridiculous
Great
thing to
point.
tell a 14-year-old. Right. And
Yeah.
so, like, for a 43-year-old to be like, well, I don't know, is like,
Yeah.
well, you're 43. You got a couple of years till average age or menopause, and you're having
Yeah.
symptoms. And the thing to say is, like, there's always other health things that it can be. Of course, it could be your thyroid.
Mhm.
Of course, it might be something else. But like, this happens to 100% of females.
Yeah.
And so it's not stupid to be like, that might be a good guess.
Yeah. Yeah. We should at least be assuming, that that's the directionality of it.
Yeah, I mean,
And,
the
and
women in their 40s get totally neglected because they're like, well, you're
yeah.
too old to get pregnant. And so they kind of give up on them in that way, which they're
Right.
not. A lot of people get pregnant in their 40s. And then they'll say, you're too early for menopause. And it's like, well, no, you're not. Right. So the women in their 40s really do get kind of dismissed on both ends
Yeah.
of the stick.
Yeah. We've really talked about that a lot, Michelle and I. That it's like women sort of disappear in their
Mm-hmm.
in their 40s.
Mm-hmm.
And it's been really frustrating to go through with Michelle. What are these symptoms that women should be looking for? Both, there'll be some common ones, but then there'll also be some that are less common, but again, still real symptoms
Yeah.
associated with this.
So one of the more common ones, and again, this isn't even in the beginning of perimenopause. There's definite, of course, researchers and stuff, like there's definitions. There's called the straw criteria for the different phases of perimenopause. So like this has all
Mhm.
been well established. But in the middle of perimenopause to the end, that's when you're going to start seeing periods space out. So that's kind of the most stereotypical one. Again, doesn't help for 1/3 of the women who don't have periods.
Mhm.
Ablation, IUD, hysterectomy. Um, is shorter intervals between periods, longer intervals between periods, really heavy periods, really light periods. Those are all not air quote normal, but it's like what to expect, right? And if they start spacing out, and because you're not getting that ovulation, which is causing that estrogen to go up. So you're not getting, the proper bleed afterwards because you didn't have the egg release, but you still got some hormones. So there's some bleeding going on. What it is called an anovulatory cycle. So you can have periods, but you're not spitting out an egg mid-cycle. So that's kind of the classic, just because we define menopause as being no periods. So perimenopause can be defined as irregular periods. Not everybody will have irregular periods in perimenopause. Trouble with sleep, trouble with anxiety, trouble with weight gain, or I weigh the exact same, but I've got this pooch down there now that I didn't used to have, but the scale hasn't changed. So the metabolism starts changing. If you were to do studies, because you can't just look at this, insulin resistance starts going up, risk of diabetes starts going up, risk of depression and anxiety skyrockets. Death by suicide is actually at its highest in the mid 40s, early 50s.
No kidding.
Women. Yeah. It's directly related to the profound hormone changes that are going on.
Wow.
So there's lots. And again, like you said, it's really retrospectively that a lot of women are like, oh, that was probably perimenopause. Because then then their period will end, or whatever. Yeah. As then they're like, okay, that's what that was.
Yeah, and I know from Michelle's experience when her hormones get off, the dry skin, the itchy skin, all of these things that sort of get dismissed. And I like that you sort of mentioned earlier, it's like, oh, you have hot flashes, great, yeah, that's what you're going for. We were having a conversation this morning, and it's not until she will say the word hot flash that she'll get a test run. Yep. All of the other stuff she lists sort of gets dismissed. Sometimes she won't be experiencing hot flash. She'll just say that just because she knows that will maybe trigger a response.
That's the word. Yeah.
The word, right. Yeah. Well, I really appreciate you highlighting some of those. And then once a woman starts noticing some of these changes, what does she do next? How can she navigate this phase of her life?
Yeah. I mean, I think the first thing, because I think a lot of people will be like, go to a doctor, get on blah, blah, blah. And I don't think so. I think the first thing is just be educated about what's going on and start doubling down on the basics, right? Like I went to the gym today. I get trained like twice a month. I'm not perfect, but I show up, and like I just did some late travel and missed some airplanes, and like my sleep was totally off, and I was like, I don't want to hit it hard today. Yeah. And so I was like, hey, can we just foam roll, do some mobility, do some stretching, blah, blah, blah. And so that's what I got to do, is like, it's really doubling down on the basics of like, you can't mess around like you could when you were 22 anymore. Yeah. Like it takes a hit. Like I used to be able to sleep anywhere. I'm a surgeon. I went through 6 years of surgical training, right? Like I could go without sleeping. I could sleep anywhere, blah, blah. Now I'm like, dude, I went to bed at 2 a.m, like 2 days ago, and I'm still recovering from it.
Right.
All right. A lot of women will say alcohol just like hits them way harder. It makes sleep way worse. So I would say the first thing to do is like doubling down on the basics. It's the stuff you guys talk about, is like sleep, clean eating. I think it's a great time to cut out alcohol. I'm pretty adamant on that. I don't think there's any safe level. That's a whole nother podcast episode, but really like
agree on that.
Bringing in like the basics for that. And then because the thing with hormones, supplementing with hormones, is there's like two camps. There's like hormones are a miracle. They're all you're going to need. They're going to keep you young forever, which is not true. And then there's the like, they're dangerous. It's a pharmaceutical. Pharmaceuticals are bad. You should just be able to do with protein intake and sleep hygiene, and maybe some cognitive behavioral therapy, of which, is great, but those things don't actually replace hormones.
Right.
And that's why I have such a challenge with the definition of menopause, because people don't know this is a profound hormone change. You have to educate them on that first, because otherwise they're like, what are you doing wanting to give me a pharmaceutical? I've never been on a pharmaceutical in my life.
Yeah. And so let's dig into that, because, we told you we got inundated with these questions. And I think it's really important to define this sort of natural approach. Many of the questions we got are, what is a natural approach to balancing my hormones during this period?
Well, to not offend the people who've never met me, like death is natural. I actually went back. So I'm writing my second book is on menopause. It's coming out in September. And I went back to do the research because people will be like, I remember my great great grandma lived to 108, like arguing that longevity actually is the default, or that humans have been good at that for a long time.
Yeah.
And the data doesn't support that. And certainly the fact that as a global population that's aging, we've never lived this long. And, there's amazing records in like the 1400s of Britain.
Right.
Who do we keep track of in the 1400s in Britain? The like aristocratic males, right? Like those are the only people that actually get their name written on a piece of very expensive paper, right?
There were other people,
right? Yeah, no. So they have the aristocratic birth and death records from men in the 1400s. So like those were the richest people with the food and the land and the power and the helpers, most wealthy people. Average age of death, 47.
Come on.
And then if you look at so antibiotics have been with us for about 100 years. Linus Pauling, like 1926, something like that. There's researchers think because of antibiotics, the average human lifespan has been extended 26 years.
That is incredible.
It's incredible.
Wow.
Incredible. But what I'm doing is I'm building a case to say, you in exceptionally good health at 84 is not natural. Right? Like you without hormones for 40 years, not natural. Have some humans done it? Yes, they have.
Of course.
But I'm talking like as a global society, when we're looking at bankrupting ourselves because of the cost of chronic disease and not being able to get out of bed and all the things, is like, what do you want to be when you're 40, when you're 74? Right. And you have to start thinking about if living healthy, strong, independent is a goal. You have to think about are our hormones going to help? Right. And you have to start the hormones around age 50. The data shows the younger, the better, because hormones prevent disease. Hormones are crappy at treating disease. Right. So all the people who are like, I want to do this naturally. And I'm like, I'll see you when you come back begging at 74, because the boomers now who got withheld from the hormones because of the WHI. So basically this massive study that said hormones cause cancer in 2002.
Right.
Big mistake. Those boomers didn't get hormones. Guess who wants their hormones at 74? Right. They do. So because they're seeing all the friends break all the hips, and they're seeing their sister with dementia, and they haven't slept well in 20 years. Right. And so to the 50-year-old who says they want to do it naturally, you have to educate on like, listen, you got here by driving your car, you're wearing socks, you have nice dental care, like you have air conditioning and heat. There's so much not natural. Why are you going to die on the stake of this one? When we know probably, like, my whole thing is like, probably living 40 years with no hormones and dying frail, like, that's what's going to happen. Not to, again, there's the exceptions. My aunt lived with no hormone, blah, blah, blah. There's always the exceptions, but it's like, by and large, hormones decrease your risk of fracture of your bone by 50%.
Wow.
Right? Like, if that's not natural, fine, I'll take it. Living to 100 is probably not natural 200 years ago. Natural is dying in childbirth 1 in 8 times. That's the natural death rate of giving birth to a child. 1 in 8 death of the mother. Nobody wants to be right. So it's like when people say they want to be natural, I love picking it apart to be like, I don't think you actually do.
Yeah. And the things you mentioned, some of those are outside the body, and people say, well, I don't want to put unnatural stuff in my body, but we do every day. Like food science is a thing because it's creating new ways to make food.
Right.
Other medications you might take, like aspirin and Advil, colon sinus, all these things, they are not natural.
Yeah. Well, I mean, and to be fair, antibiotics, how we've created them, aren't natural.
Right. Because
we've made them in factories, right? Like, is there a mold somewhere you could have run into that would have cured you? Like, possibly. But it's like, they've extended the human lifespan by 26 years per person. And so you're like, I just think the natural argument falls apart so fast.
Yeah. Well, especially seeing as your body does make these naturally.
Well, that's the thing. I mean, that's what I struggle with, because I'm like, listen, a high blood pressure pill, that's a drug. Cholesterol medication, that's a drug. Antidepressant, that's a drug. Something your body naturally makes that you're just putting back, not even in higher amounts, but like actually lower amounts. Like, do I call that a drug? Do you call that a medicine? Why? Because it's so profoundly different than the average pharmaceutical, which is created. Like, I think there should be another name for it. I'm not smart enough to think that up or brand it, but but you know, that's the way I think about it.
Yeah, I think it's such an important point, because I think we have to shift that narrative, because a lot of people, because they want to do this natural thing, somehow now supplements have started to fall into this natural category. So I'm going to go over here and talk to this person who owns this natural food store, and I'm going to do these supplements to balance my hormones.
Yeah.
And so, you know, that I think there's a lot of danger there, because we don't know what's in any of this stuff.
Well, that's the thing. It's people don't understand how unregulated it is, and the marketing of, because it's not big pharma, it must be safer, instead of like, do you know what it takes to get something FDA approved? Like,
Right.
It's got to work better than placebo, and placebo works very well. A lot of supplements do work because of placebo, and then they wear off. But it's also, you know, you hear of the things that like, and then it causes these people liver damage because they're not tested. Besides the fact that they're incredibly costly. And besides the fact people are like, well, I don't like big pharma, but I'll go spend $500 a month on these proprietary blends. And it's like, you know who the biggest investor in supplements is? Big pharma, right? Like, it's so cute that you think they're not the same thing. They are.
Right. These little mom and pop supplement companies that are, you know, $1 trillion business.
Yeah. Well, I think especially for perimenopause and postmenopausal women, because of the damage done with the WHI to be like, the worst thing we did was to tell women to be afraid of something their body naturally makes. Like, that's insanity. Okay. So we did that, and then we sell them things by saying non-hormonal.
Yeah.
Right. And you're like, dude, there's nothing that works better than the hormones. Like, do we have non-hormonal options? Yes, we do.
Right.
They do not work better. And many would say they work much worse. Like, we have a new FDA approved non-hormonal medication for hot flashes. Does it work better than hormones? No. Is it 20 times the cost? Yes. Do we have long-term safety data on it? No. Right. So just because it says non-hormonal or natural, I always joke, you can put natural on a candy bar and charge more money, right?
Of course you can.
Natural on a candy bar is meaningless. It's marketing.
Right. Well, and that's, you know, another little segue here, but that's what we always talk about when we're coaching people in nutrition is read the back of the packet, not the front. Right. Who cares what it says on the front?
Yeah.
They'll put it in a nice matte paper finish and put a picture of a farm on it and say it's all natural. And then you turn it over and read the ingredients list.
Totally. And the company is like, natural. The company is a subsidiary of Pfizer, right? Like, not to pick on Pfizer, they legitimized erectile dysfunction treatment. It's not all bad, but you know, that'll be people's argument is like, I truly think people who, you know, like want to do things natural, they come from a good place. Like they come from, I don't want to hurt myself. Right. Like, I understand where they're coming from, but a little bit of education on that. And then they're like, oh, well, I mean, if you're lifting weights 3 times a week because you want to preserve your muscle function and your bone function and your balance, right? Like, you can be like, well, I can do other things that might also help my body be strong. I mean, we don't make our own fiber. We have to take that. We have to put that in our body. Yeah. Right. And so it's like, there's things we have to do.
Right. And so that there's a great sort of yes and there. You know, we talk about all of these natural approaches. We must be lifting weights, right? The bones, the muscles need mechanical stress through heavy weights to adapt. I think a lot of people think of bone as this, it's basically a stick that's in their leg, right? It's a static object.
It is what it is, and you wave the hand.
Yes.
Right. And people are shocked, doctors too, when they're like, I had osteoporosis and I reversed it. I had osteopenia and I
Right.
reversed it. And, it's like, we can't reverse all disease. We can't do that.
Mhm.
But what your diet does, what your physical activity does, what
Yes.
proper hormones do is like, you can make things strong again. We're
Yes.
amazingly adaptable bodies. It's very cool.
Well, I mean, it's the whole principle of training.
Yeah.
It's adaptive overload, right? So we put a progressively increasing load on the body. The muscle gets stronger, but the muscle is acting on the bone.
Yep.
So as it pulls harder, now the bone has to adapt as well.
Yep. Yeah, I mean, a common thing.
Yes, we have to do that. And then we have to add the hormones to complement that and help facilitate that process.
I think some of the biggest supports, I mean, I was at my gym and a woman there's like, yeah, my trainer, 26-year-old guy trainer, encouraged her to go talk to her doctor about hormones. It's like the physical fitness people understand and they see it. And I'm pretty pro female testosterone, and because I'm a urologist and I give 10 times the dose to the dudes every Tuesday, right? I'm not afraid of this hormone. It's gotten its own bad branding. And somebody was like, they were like, well, are women just going to make muscles by giving them testosterone? It's like, not if they're not eating and not if they're sitting on the couch. Like, the hormone will not, it's only one thing. You have to do all the things.
Yes, that's exactly right. And I think that with the weight training, that even if you work at, like, I've been trying my whole life to get as big as I can possibly get.
Women are like, we don't want to bulk. And the men are like, good luck.
I love your confidence.
Yeah.
It's so hard. Right?
It's really hard.
Like, it's hard to eat enough to
You
bulk
have to
up.
eat. You have to eat
so
tons.
Much. Yeah.
And I think, we were talking about this when we were having dinner, is like, especially Gen X. And I would say, the boomers, is like, growing up, the women were trained. Thinness is perfection. Thinness is female. Thinness is beauty. And it's like, those role models did not have muscle. And it's like, dude, I don't know how Kate Moss is going to age. She smoked cigarettes for like 30 years, probably not well. But now that we're in this perimenopause, menopause world, it's like, you literally have to redo the programming.
Yeah.
Because what got you here is not going to get you to being on the ground playing with your grandkids, traveling to Sardinia when you're 84.
Exactly right. Yeah, we did have that conversation. And I think that starting with, what do you want to be doing? You mentioned earlier, what do you want to be doing at 74? We use 90, right? We want to be thriving until people aren't thriving anymore, right? Until you're done. And so with that in mind, it's just the same as training athletes. Like, if you're starting here and you want to be here, right? How do we train you to meet that demand in the future? And if, I said the other day, like, if you can't get off the floor today, what makes you think you're going to be playing pickleball at 90?
Yeah, totally.
And it's the same thing. We've conditioned women to eat and exercise to be thin.
Yes.
So many people are coming to us with osteoporosis who have exercised their whole life, but it's all been cardio and yoga and body weight. And, somebody explaining the other day that they went through this real, like, sort of masculine energy phase, and they were doing all these weights at core power yoga, right? So you're holding an object in your hand and say, okay, I'm doing weights now, without a consideration to the mechanical load that's necessary.
Yeah, I mean, especially for women, like, even just rebranding it, they called it toning. You're going to tone. Like, they even took the words like weight training and getting strong, and like they took it even out of what a feminine exercise is. So it really is a rebranding and an ownership of, like, you can do with your body what you want. It just might not be what was idolized in the 90s.
Yeah.
And I think for the hormones, like, there's so many women. I mean, again, looking at depression rates, anxiety, right? Like, these are neurohormones. The fact that part of these are made in testicles and ovaries actually diminishes it a little bit, because sex is always thought of as like extra or not important. But it's like, these are in the brain. They're so important. The brain makes them. The brain makes testosterone, smaller amounts than the gonads do, but like, the brain makes them. The brain has receptors for them. And it's like, if you aren't sleeping, if you don't feel like yourself, how the hell are you going to get to the gym and lift weights? Right.
Yeah.
And that's that counter. That's the fifth argument against natural. And I see this a lot more in men is, well, you should be able to just lose the weight and start going to the gym and your testosterone should go up naturally because you do have testicles that by and large should continue until you want to die. Right. But they've got such low energy, they can't even think of going to the gym.
Right.
Right. So you have to like give them the hormone first if they have low hormone, if they have low testosterone. Right. And then they actually feel like then going to the gym.
Yeah.
Right. And so many people are like, well, we'll only do this if you fail all the natural things first. It's like, you can't even think about lifting weights 3 times a week if you aren't even sleeping and you have horrible anxiety and depression. Right. So it's like meeting people where they are and not giving them the like, well, try all the natural things first. And only if you fail, like that's mean.
Yeah. Well, and it really does set people up for failure and continues this narrative. And I think a hot topic is testosterone in women. Your body produces it
4 times the amount of estrogen.
Right. And
like a large amount of it, just less than men.
Less than men, but significant.
More than estrogen.
Michelle has been to the doctor and been measured testosterone at physiologically 0. And yet people have everything from, well, we're not going to give you testosterone because you might give it to Jeremy. Yep.
Oh, so I don't trust you. That's a great relationship to build on.
Yeah, really, really strong,
really professional. Perfect.
Yeah. So my bodybuilding career went right out the window.
Yeah. Men, if you're using your woman to use 1/10 the dose of testosterone for your bodybuilding career, it's going to take a long time.
Yeah. And so this is the hardest thing that Michelle has had to fight for is measuring testosterone and being prescribed it.
Yep.
Being invalidated, sort of diminished, whatever she goes in and talks about, it's always challenged with some, you're expecting too much from your hormones. That's not a symptom, down to libido, like almost like, well, what do you want to be doing that for, at your age? Meanwhile, Michelle had a hysterectomy in her 30s, right? So, and even we'll talk about measurement and best practice there. Michelle should be pretty stable, right? She went through surgical menopause, and so we shouldn't be worried too much about. We're not going to measure it.
It should just be low,
right? And so that I think sort of debunking some of the testosterone stuff for women, because it creates a visceral reaction when you start talking about that in many, many women that we speak to. So can you talk through some of the importance of it and what are the impacts that it can have for women?
Yeah, absolutely. It's one of my favorite topics. And I just say thank you so much for sharing and for Michelle for allowing her story to be shared, because Michelle's incredibly intelligent. She has resources. She lives in one of the most resource intensive places in America. And if she has a challenge for healthcare, think about everybody else.
Well, and not only now do we. I spent my career, the last 20 years, we've been in professional sport. We've had access to whatever medical system we needed. Right? Like I went in and hired hospital systems for teams, and they rolled out the red carpet for the players, the staff, the families. Right? And that's what we've had to fight through.
Yeah, everybody else is effed.
Sounds away from today's episode.
Yeah, exactly. Okay, so the first thing you have to do, which I think we've already done, is we've established that ovaries make testosterone, adrenal glands make testosterone, and the brain makes testosterone, the peripheral conversion in women. So those are it's like 50-50 and then a little bit of peripheral conversion in women. Whereas in men, the majority of the testosterone is made in the testicles. So women make 4 times the amount of testosterone than estrogen. You cannot get estrogen in your body without converting it from testosterone. So cholesterol pathway for any biochem nerds. You got the cholesterol, 21 carbons. Then we go down to progesterone. We go down to testosterone. Then we cut another carbon off of it. And then we have estrogen. So we make estrogen from the testosterone. But the other myth of that is like, I don't want to give you testosterone because it's just all going to convert to estrogen. No, it's not. We have 4 times the amount of testosterone than estrogen in our body. It's not all converting. Right. And they've done very glamorous studies of actually giving women aromatase inhibitors, which block testosterone to converting to estrogen, and seeing, well, how do you feel? Do you feel better? Right. So they've done glamorous studies looking at that, because people will be like, well, giving you testosterone, it's only making you feel better because it's converting to estrogen. We're like, no, we've blocked it. It still makes people feel better. The biggest myth I see, there's a lot of problems with testosterone. The biggest myth I see, the one that irritates me the most at this current moment, is people being like, you can't use it for mood or energy. We don't have enough data, but you can use it for libido. And I'm like, libido's a mood. Like, it's literally called getting in the mood. Like,
Yes.
So that drives me insane when people are like, it's only for libido. It's not for anything else that could go on in the brain. And I'm like, where do you think libido is in the brain? Is it like walled off where testosterone only goes to the libido center? Like, no, this is brain. And so that's like my biggest annoyance. There's also regulatory annoyances. We do not have an FDA approved medication in America for testosterone for women. Australia has it. It's coming in New Zealand. It's going to be in South Africa. The UK is then going to get it. We're probably going to get it after all of those countries.
Was that the case? Different podcast?
Different podcast. Well, we actually, a testosterone patch, I think it was called the Intrinsa patch, went up to the FDA very shortly after the Women's Health Initiative dropped.
Mm-hmm.
Women's Health Initiative dropped in 2002. We just thought hormones kill people and give you cancer. So then we're like, here, how about giving women testosterone in a patch form for their libido? And they were like, bah! Right. So men to get the male testosterone, they needed 6 months of safety data. Mm-hmm. The FDA for the female one, because it came out just on the tail end of this catastrophe saying hormones cause cancer, which for anybody who isn't caught up, hormones don't cause cancer, is they said, we want 5 year safety data. And just for people who are listening, 5 year safety data for an FDA study, that's $1 billion.
Wow.
Yeah. So what pharmaceutical company is going to say, hey, I'm going to try to get an FDA approved generic natural hormone that's basically not patentable, but spend $1 million to do that? You're not going to make any money. What investor is going to invest in that? Right. So it's really like gender bias with some bad data of the WHI combined with like profitability. Those are all the reasons. We could have had them. There actually was a patch in Europe only for surgically menopausal women. And it got taken off the market, not because it was unsafe, not because it didn't work. They just didn't sell a lot of it. So surgical menopause, again, much smaller niche than natural menopause. But that's why that got taken off. So the moment is now, because never before have women looked at their mothers and grandmothers and been like, what if I age differently?
Yeah.
Right. And what if I don't want my marriage to end? And I want a sex life, and I want to want. And so it's really this, like, I would say Gen X really is redefining perimenopause and menopause. The elder millennials, they're like right on the tails. I truly think in the future, do I want everybody to be on hormones? No, but I want everybody to be educated. And if you're not going to, I want you to choose wisely why you're not to, and not have it be because it's natural, because that falls apart in a hot second. But I really think in the future, it's going to be, why are we waiting for women to suffer? Yeah. Why are we, 1 in 9 women drop out of work because of untreated menopause? One of the largest reasons relationships end is because of untreated intimacy. Like, this is a big problem. Why are we waiting for women to suffer instead of saying, hey, you're 47. Let's see how your bones are doing. What are you doing with alcohol? How are you sleeping? How do you want it? What do you like? Being proactive and choosing, the biggest bone loss is the 2 years before your period ends. So profound bone loss in perimenopause. But again, we can't test for that. How do you know when your period's going to end? Right. So I think hormones are really going to start being preventative medicine.
Yeah, I think that's immediately what was going through my mind, is this reactive, it's an extension of the reactive medical model.
Yes.
We wait until somebody's already got the condition and then we want to treat it.
The amount of women who come to me and they say, my doctor says I'm not sick enough yet.
Well, that's exactly the thing with Michelle.
Yeah, right. Like Michelle, you look too good. You look too good.
Yeah. Your skin's not cracking and bleeding yet. Not bad enough to give you a remedy.
Yeah. You don't have an autoimmune disorder yet. Like. Yeah, exactly.
And so I think there are ways that we can screen for that. What if instead of waiting until people are 65 to get a DEXA, it starts getting built in every year as preventative screening?
Yeah.
And we can track this and create our interventions and know when some of these physiological changes are actually starting to happen. We have baselines.
Totally. And I think the other thing is insulin resistance, fasting glucose, A1C, cholesterol, triglycerides going up. Like there are blood tests we can do to be like, you can't feel your metabolism changing.
Right.
But I mean, here's a ridiculous thing. So they took a bunch of perimenopausal women who were pre-diabetic. Okay. So they had some pre-diabetes. They weren't sick enough yet, but they had pre-diabetes. And almost. So they had pre-diabetic perimenopausal women. They put half of them on estrogen and then they put half of them on placebo and they followed them for a year. The women on estrogen decreased their risk of turning into diabetes by 30%.
Wow.
They didn't change anything else. They didn't change their diet. They didn't change their exercise. They just put them on estrogen. And I'm like, if you had a drug that decreased your risk of developing diabetes by 30%, that would be an effing blockbuster. But hormones are generic. People don't make a lot of money off of them, right? It's like 30% didn't get, compared to the people who are on placebo. It's insane, the power of hormones, but nobody knows about that.
I think that this conversation, it's blowing my mind. I had no idea. Imagine that.
Wait, Jeremy, there's more. They did one where they said, what if hormones for the prevention of depression? So they took perimenopausal women, they put these on placebo, they put these on estrogen, followed them for a year, decreased their risk of developing depression. Like, it's insane.
And to your earlier point, imagine this as a force multiplier to all of the lifestyle factors we can put in. I've experienced tons of very deep episodes with depression. I know all of the lifestyle things to get out of it. You know how freaking hard it is when you're in the black hole to get up and go to the gym?
Yep. Impossible.
I know it helps me. I know it helps me.
Right. Yeah.
Of course I do. Connect with Michelle, all these things. The last thing you want to do.
Yep.
As a force multiplier, if we can just, as you said, give people a leg up to have access to these lifestyle modifications, that is profound. Reducing the risk on top of having a great cardiovascular and weight training program to then have something else that further decreases your risk of diabetes by 30%.
It's insane.
The magnitude of the change you could create is just unbelievable.
Well, if you just look at, it's like pick something, right? The amount of hospitalizations in America for hip fracture is equal to that of heart attacks and stroke, right? But it's a completely silent thing, right? Because grandmas don't have great social media channels. So people don't know it. But it's like, if hormones did nothing but just decrease your risk of fracture by 50%, which is what they do. That's what the WHI study showed. Even in women who did not have a diagnosis of osteoporosis. Just being on hormones decrease. Because it's like, you don't go from like normal healthy bone to osteoporosis, right? These aren't binary things.
Right.
Like, well, how did they help the people without osteoporosis? Because it still made those bones stronger.
Yeah. And interesting point, how did that not make it out of the WHI, but you get cancer did?
Yeah. Oh, wait, there's more. So the WHI for women who had hysterectomies, right? So the Michelles of the WHI who just took estrogen, they didn't take remember, these were synthetic hormones as well. They're not what your body made. So they just took estrogen. They did not take the synthetic progesterone. It decreased their risk of breast cancer by 20 to 30%. And wait, there's more. If you ended up getting breast cancer, but you were on estrogen, because breast cancer is common, we can't 100% prevent it, blah, blah, blah. So if you were on estrogen and you got breast cancer, your risk of death was 40% less than women who hadn't been on hormones.
Are you kidding me?
No.
Unbelievable.
So the media said hormones cause cancer. The truth was estrogen decreased your risk of cancer, and heaven forbid if you got breast cancer, it decreased your risk of dying by about 40%.
So explain to me where that message came from then.
I'm not in. You can get conspiracy a little quick on this because it's so atrocious, it's hard to otherwise explain.
Right.
Not all doctors who are involved in the WHI thought it was reasonable to go to the media with this. There were a handful of physicians who wanted to put the nail in the coffin for estrogen. Now, do I think at some point an investigative journalist is going to say, hey, these people were involved in some pharmaceuticals that did things that possibly, I mean, to me, I'm like, I can't prove it. It's not my job to prove it. But doctors knew it wasn't that bad. They went to the media before the paper was published, which is a big academic no-no. Paper got published about a week after the media broke. Then the doctors can read the paper and be like, this is not statistically significant. It never held up, even 5 years after, even 10 years after. And at the moment, one of the doctors told the other one and said, if you go on record and say that hormones cause breast cancer, we will never put the genie back in the bottle.
Right.
And they were 100% correct.
Because once it's in the media, it doesn't matter about a retraction. You believe the first thing you read.
Yeah, that makes the news. The retractions have never. And another important paper came out like last year from some of the authors of the WHI. And they're like, the benefit of hormones outweighs the risk for the majority of women. Like, that's a profound statement. That the benefit outweighs the risk is a very strong statement in the medical world.
Yeah.
That didn't make the news. But fear sells. And I truly believe the best way to control women is to keep them afraid.
Yeah.
And this did a very good job of doing those things.
Yeah. Well, yeah. Michelle is producing in the back here and is sort of all caps the patriarchy, you know.
Well, I mean, I think that's why, like, what's happening right now, you know, with doctors like me and the social media and the podcast and you, is like, the ship is turning because of educated, pissed off individuals.
Yeah.
It's not coming. The change is not coming top down. Now, doctors are changing because they're like, damn it, I got 6 people in my office this week asking for hormones. I better learn, right? Like, that's how it's changing. But the doctors who know were like, it's much easier to actually go educate the people, have them go in and say, I want to try X, Y, and Z. And we're actually teaching people how to talk to their doctors, right? Yeah. Like, that's actually easier because doctors are busy. Like, I mean, the other crazy thing is, like, our healthcare system's so full right now. Like, you can't get in for an earache.
Yeah.
There's 80 million women over the age of 40 in America.
Yeah.
Right? Like, access is a huge problem. It's like, I can give you education, but it's still hard to get in.
So let's talk more about that. With this struggle that Michelle's had, she is far from being alone. How do women, you know, you might have a 10-minute appointment.
Yeah.
First of all, who should the woman be going to see? What is the area of medicine that she needs to spend her focus on? And then what are the questions? How does she advocate for herself? Yeah,
good questions. So there isn't one type of doctor that takes care of 50% of humans, right? Yeah. Like, that's the other thing. You've got to blow it open. Because people are like, got my gynecologist. And I'm like, the fact that you think there's one doctor or one type of doctor to take care of 50% of the humans just tells you what a bad setup the women have to begin with, right? So very early in my social media, of somebody who didn't like that I was being loud was like, she's a urologist getting into menopause. And I'm like, excuse me? This is 50% of humans. We should all have gotten into menopause already. Like, cardiologists, number one reason a woman in her 40s and 50s goes to a cardiologist, heart palpitations. It is a very rarely known sign of menopause and perimenopause.
Wow.
People don't, like, cardiologists need to know this, right? So many women, they go in and they're like, I got the heart monitor, I got the EKG, I got all the blood work, and they say I'm fine. I'm like, yeah, but you're still having heart palpitations, right? Like, they didn't fix the problem. They just told you didn't have a heart attack. I had a friend, she's a surgeon, and we were like drinking coffee in the surgeon's lounge, and she's like, my heart palpitations are so bad, I won't drive with my kids in the car anymore because I feel like so unsafe. Got all the tests, saw the cardiologist, got the work, has access, she's a surgeon, everything's fine. Great, you still don't want to drive with your kids in the car, right? And I was like, you're 48, it's probably your hormones, why don't you get on some hormones? So she goes to her doctor, gets on some hormones, and she's like, my heart palpitations stopped. And I'm like, yeah, because you have estrogen receptors in your sinoatrial node in your heart, right? Like, it's important for electrical conduction. So people don't know this. So anyways, the point is there's not one type of doctor. Family medicine, internal medicine. I wish more endocrinologists did this. Gynecologists are getting better, but again, they're busy taking care of the bleeding and the babies and the hysterectomies and like the birth control, and like they're busy. They didn't get trained. And not all urologists, 10% of urologists are female. Right. So people are like, oh, so I just need to find a urologist like you. And I'm like, good luck. There's 1,000 of us in this country. So this is my biggest advice. Two pieces of advice. Don't make the appointment, go into the appointment and then ask, do you treat menopause and perimenopause? Because if they say no, you've wasted your time. Right. Exactly. So website, their social media, ask the receptionist, is Dr. blah, blah, blah comfortable treating hormones? If they are, the receptionist should know this, right? So my first part is like, don't waste your time and your money and then ask the person in the room. Because if the answer is no, you're back to ground zero. So know before you go.
And it's another 2 years before you can get an appointment.
Yeah. So who are your friends seeing? Blah, blah, blah. There's actually, this is not great for testosterone, again, because of federal DEA regulations, which we're trying to deregulate testosterone. That's a sporting story, Jeremy. That's a good one. Because of the Olympic doping scandals of the 1980s, Congress passed the Anti-Doping Act of 1991, putting all synthetics on there except for testosterone, which is the only natural hormone that is now regulated, like ketamine and Tylenol with codeine. So because of that, you can't do it with, across state lines. You need DEAs. It's hard to do with telemedicine. You have to get refills every 6 months instead of every 1 year. So one of my platforms is, because it literally is an act of Congress because Congress did it. Yeah. Congress has to undo it. So hopefully maybe with this administration, we'll deregulate testosterone. It's one of my goals. So testosterone's tricky, but the point is there's a lot of online menopause and hormone clinics now that are being created to help the need. Alloy, Interlude's great for vaginal estrogen, Genev, MIDI, Evernow. Those are 5 off the top of my hands. Those are all online telemedicine. Some take insurance, some do not. And then, so now you're sitting in front of a doctor or a nurse practitioner, they treat hormones, or maybe they don't, but they are willing to learn. Say, I have X, Y, and Z. Be clear, be specific, and don't hide your suffering. If you say I have hot flashes or I'm not sleeping well, that's very different than I have 18 pairs of pajamas because I have to change them 4 times a night because I'm so wet and soaked that I can't get any sleep. That's specific and explains your suffering much better than I'm not sleeping well and I've got a hot flash. All right. So be clear about your suffering. It's not a time to be stoic. It's not a time to tough it out. You need to clearly communicate what you need help with and then say, can I try X? I will make a follow-up appointment in 3 months. We will check in and adjust as needed. Doctors love follow-up. They love knowing if something worked or not. So those are the tips. Know if they're going to help before you even show up, and then ask for what you want. And then say, I will follow up. We will adjust as needed. So
something you mentioned in there are these follow-ups and monitoring. Again, we'll go back to a Michelle experience. She has paid a lot of money to go to a specialist who would not measure her hormones because of the fluctuations.
But she doesn't have ovaries?
Correct.
Good God.
Right. So
did they go to medical school?
Yeah, I assume so. So what's really important here is, for me in sport, we prevented injuries by measuring and then frequently monitoring. What is, in your view, best practice for monitoring for women who are going through perimenopause, but then also for women who have been through surgical menopause and should be relatively more stable, but are still feeling suboptimal?
Yeah, Great question. So it's tricky, and you get the spectrum of like, come to me because I'm going to test you frequently and excessively, and it's going to cost you tons of money. I think a lot of that's overkill. I think we don't have a lot, especially when you get into the metabolites of things. Like, we do not have data to say what optimal should be, and it gets a little fringy and very expensive because we all hope to live 40 years past our ovaries, right? So like long term, that's why a lot of the expensive things don't hold up for people. So there's that end. And then there's the other end, which say, hey, I'm not going to test them. And there's a little bit of truth in that. What do I mean by that? If you're 5 years post menopause or you've had your ovaries removed, I'm a good clinician. I don't need to check your blood levels to know you're going to be low. You're just going to be low. But people, it's validating to get things checked. It's cheap. It's not my blood you're drawing, right? It's like to get some basic labs. It's very cheap. Get some baseline. But are they correct in saying I don't need to draw your blood levels because your hormones will be low? Yeah, they're correct. Like, I had this like 67-year-old. She's like, will you check and see what my hormones are? And I'm like, I'll check right now. They're zero, right? Like, you haven't had a period in 20 years, you know?
Right.
So like, you don't have to check. And then the purists will be like, you don't have to check your hormones post-menopause because they're low by definition. You can't get pregnant, right? So there's that. And then in perimenopause, it's the roller coaster, right? And so that's even a little bit more tricky because if I check your labs on Tuesday in May, that's not what they're going to be on Wednesday in July, right? Because they're not only cycling. You can try to be like, oh, let's check them day 4 after your period. So they should like, let's see how low, like you can kind of optimize it, but like 1 month to the next is also going to be different. So people so what, and this is what bothers me. And people will be like, I'm estrogen dominant. Like that's like a fixed state, like your bones, right? You just are estrogen dominant. It's like, well, no, on Tuesday when you got your labs drawn, it was high, but that's not how you are by and large. And I'm talking average people without an endocrine disorder and, you know, things like that. So people will latch on to like that one lab day and then be like, that's how I am. And it's like, no, like we're always changing.
That's a timestamp.
Yeah, exactly. Like that was a time. Yeah. And so if you can interpret that as a timestamp, get your labs drawn. I don't care. It's not going to hurt you. But don't hang on to that. Like that's the fixed state for the next 20 years because that's not what it is. So what do we care about? If we're saying labs may or may not be helpful in perimenopause, blah, blah, we care about how she feels. Yeah. How do you feel? And so we'll put you on estrogen and then people will say, well, we don't have to check because we don't actually know what the optimal number for you to be at, which is true. Like your optimal number might be 50. My optimal number might be 80. We don't know. We haven't studied this enough. Right. But if you're like, I'm still having hot flashes, I'm on the maximal dose of this patch and I'm still super cranky and blah, blah, check it because you can be a poor absorber of transdermal formulations. You might be a fast metabolizer, right? I had this woman, this is a good example. I had this woman, she was on a hefty dose of estrogen because she swore it was because it was she swore low estrogen was why she wasn't sleeping. So she was like, more. And remember, you can have like insomnia disorders and everything isn't just menopause, right? Yeah. Women are allowed to have other issues happening. But so I was like, hey, before we go, so she's like, more. And I'm like, okay, before we give you more estrogen, let's just check your labs and see where you are. Right. She had an estrogen of 1,000. It's very high. And she's like, is that high? And I'm like, well, not if you want to sustain a pregnancy. Right. But at 62, that's high. But I'm like, good news. Your lack of sleep is not because of low estrogen. Right. So are labs useful? Yes. Should you spend thousands of dollars on them quarterly? Probably not. Do you need an expert who can interpret them well? Yes. I mean, the other problem with testosterone, for example, is women have 1/10 to 1/20th the dose of men. So if you check like a standardized male testosterone lab value, it's worthless at measuring testosterone's under 100, which means it's worthless for measuring women's testosterone. Right. So you need the mass spec lab specifically. And for anybody who wants that, it'll say male, female, child testosterone. That's a mass spectrometry lab. But even those normals aren't like they're those normals are picked because of one or two papers. And one of them, it's Quest or LabCorp, one of their testosterone normals goes down to 2. And I'm like, testosterone experts know 2 is not a normal female testosterone level, right? But the caveat of that is people will be like, what should my goal testosterone level be? And it's like, we kind of know ranges. I know when you're going to start getting some masculine characteristics. Like I know the range I want to get you in, but like there's no range that's like, that's where you have to be and you're going to have a great libido. Libido's complicated, super complicated. So because people will just be like, they're like, tell me what to get at. And you're like,
right.
It's not that simple. We're not, it'd be great if we were all Toyotas, you know, a full tank means a full tank.
It would be much easier.
We don't have that.
It's really interesting that you say that. One of the guests that we had on previously, he was talking to some researchers. You know, some people really like the animal studies because, you know, no placebo and all this sort of stuff. And in talking to the researchers, he said, one of the craziest facts I've ever been exposed to is we use male rats. So not only is the human research white college dudes, the animal research is male rats. And he's like, why male rats? He's like, well, because the female rats have this cycle and the reactions are so unpredictable. And he was just like, yeah,
exactly.
Shouldn't you know that? Right. And so I think that none of the data is really, really dialed in on where women should be. And one of the challenges I think for people is even in that, well, how are you feeling? I don't know what the symptoms are. You know, well, you don't have symptoms. We don't need to test. But I don't feel great.
Yeah.
Right. I feel like I could be better.
Yeah. Yeah.
And so how do women communicate that and talk about, because again, Michelle's hormones should be pretty steady. She's on the patch. She's taking her hormones, but just doesn't feel quite right.
Yeah, they're just starting to look at this. There's a couple of papers published. It's called NFLM, not feeling like myself. And that's a tricky thing. So not feeling like myself is actually very common in perimenopause and menopause. The data says about 40% of women will be like, I don't feel like myself. And it's like, how the hell do you measure that? Right? Like it is very challenging for the Western medical system of like, can I x-ray that? Is there a blood draw? But it is real. It is reproducible. And women know when they feel like themselves. Right. And I would say, like, you know, going back to the testosterone and it getting very pigeonholed in this libido thing is like when women come back to me after we've put them on testosterone, they say, I feel like myself again. And to me, I'm like, that is the single most best thing of my day when a woman's like, I feel like, because now I know she's going to go. Like, she's going to go start the company. She's going to go start working out. She's going to start caring about relationships again. She's going to start all the things. And so, like, the not feeling like myself, it's so intangible with our current measuring systems, but I would say is one of the most satisfying, profound, essential parts of health.
Yeah. Wow. I felt that in my body. I can feel that you.
Thanks for coming to my TED Talk.
So passionate about that. Yeah. All right. Now I've got to move us along. I want to keep this conversation going for the rest of the day, but we had so many questions, as we've said over and over. So let's dive into some of those, and maybe we'll go somewhat quickly through them. Let's talk libido. Testosterone has been sort of held up there as the thing that women need to do for libido, men too. One of the questions: how can we naturally improve libido? So first of all, what is it?
Yeah. So libido, it's like a whole podcast. Sorry, Jeremy. So libido was named by Freud, and Freud effed up a whole bunch of things for us. So like Freud coined libido as an appetitive, which is a super fun word, a appetitive drive. And what that means is like hunger, like thirst, like sleep, like the more you don't have it, the more you need it or want it. That's not actually how sex is for a lot of people. A lot of people will be like, haven't had it in a while, don't want it. The less I have it, the less I want it, right? Like for many people, it's not appetitive, but it's important to have this history lesson because it's the stereotype of what normal is. And that's what Hollywood says it is. And that's how Hollywood's portraying it, is like, you should just spontaneously want to have sex all the time. May I keep in mind that would be devastating for most modern workplaces if people had appetitive sex drives all the time. Like, it's actually a very bad idea for functioning society.
Right.
So, stereotypically, you're going to have an appetitive, or what they call spontaneous sex drive. The younger you are, the higher hormones you have, the less stressed you are, where you are in your cycle for women. Birth control is horrible for sex drive because it blocks your testosterone. In men, estrogen's important for sex drive, which is important for the hormone clinics that block the estrogen in men. For women, estrogen is important for sex drive. It's not just testosterone. I have a lot of women that get put on an estrogen patch and they're like, I'm good. Like, this is amazing. Right. So that's the spontaneous part. And then there's the responsive part, which is actually much more common the older we get and the more we get into long-term monogamous relationships, which to the brain, newness in relationships ends at about 12 to 18 months. So if you're in a 4-year relationship, that's not exciting and new to your brain anymore. You have to do things that make it want to be exciting and new, like doing fun activities with your partner, spending time with them, liking them. Non-sexual touch is actually very important. Connection through the day is actually very important. Dancing is amazing. Watching something your partner is good at is actually a big turn on for people. Watching them build something, watching them do a presentation, watching them parent, watching them cook, like watching them do something they're good at. So there's lots of, I don't want to say hacks, but like there's lots of natural things that increase desire in you. Regular sleep, exercise. Every quadrant of increasing exercise in the week increases libido, except for the highest quadrant, the thought being those were probably over exercisers and doing it for unhealthy reasons. So exercise seems to help up into a point, then the over exercising, their libido goes down again. So sleep, exercise, feeling like yourself is actually hugely important. Body image, how close you match up to what society currently says is sexy. Right. And so that's a very, very important. So if society says these are the features that we consider sexy now, keep in mind what we think now is very different than what we thought in the 90s. Right. Like it's ever changing. It's fake. And people use that to be like, how am I matching up to who's allowed to desire, who's allowed to have pleasure? So sex is wonderfully complicated. Alcohol's horrible for erections. Nobody knows that. So
I think some people know that.
Perfect. Good. There's this amazing study out of China. It was men who drank, who had erectile dysfunction. Somehow they got them to like completely abstain for like 2 or 3 months. And then they measured erectile dysfunction again and like completely reversed to like significantly better in the majority of the men. Like alcohol is horrible for it. Smoking's horrible for it. So one woman's like, I've been on testosterone for a year and I still have low libido. And I have a lot of questions about that. Like, what's your level? How are you dosing? Blah, 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 blah. Is there estrogen involved? Right. And, do you have good adult sex ed? Because testosterone's not a light switch. For some people it is. You get that testosterone high enough, God bless America, but not for everybody.
Yeah. I think that whole biopsychosocial model, I think it's a really great point there. Another question that came in was around bladder health. And so a lot of people, I think, experience this. And I'd like to maybe here we touch on sort of the different forms or applications of estrogen here. So systemic, transdermal, vaginal estrogen. Because one of the questions was around interstitial cystitis and people sort of getting diagnosed with that in that perimenopause, menopause time in life, and that not really being cleared up with the typical treatments. And so can you speak a little bit about the changes in bladder health as we go through this phase?
Yeah. So the term genital urinary syndrome of menopause is a mouthful, but it's called GSM. And it's basically, again, going back to the beginning when we said nobody knows what menopause actually is, right? It's a profound lowering of hormones. So once you know that, then GSM makes a lot more sense because you're like, why does your bladder go crazy when you don't have periods anymore? right? It's like because the bladder has estrogen receptors in it, and estrogen's important for the function of the smooth muscle of the bladder, right? Oh, now we know that. So it makes perfect sense when the bladder gets a little wonky post-menopause, perimenopause, post-menopause. So urinary frequency, urinary leakage, overactive bladder. I got to pee all the time, running water, key in the door, getting up at night to pee, what we call nocturia. Stress incontinence, which is leaking with cough, sneeze, laugh, box jumps, jumping jacks. So local hormones, or what we call vaginal estrogen, that is applied to the vagina. I like the cream because you can put it on the vulva and the clitoris and help your sex life as well. But it comes in rings, tabs, creams, pretty darn cheap. That's local hormones. It doesn't go in your body. It certainly doesn't cause cancer. It's available over the counter in multiple countries because it's so stinking safe. Wow. The trending off-label thing now is to put some of your vaginal estrogen cream on your face.
Oh, no kidding.
Yeah. Because estrogen helps collagen. It helps blood flow. It makes your skin look great. So off-label, but we're like, it works so well on because it's just skincare, right?
Right.
So you put it in the vagina, and the vagina shares a wall with the bladder. That's how it helps the bladder. People will get increased urinary tract infections because when estrogen goes down, your lactobacillus die off in the vagina, and your vagina has a natural microbiome. So the microbiome changes. It can't protect all the stool and poop bugs from now traveling up into the bladder. You need an acidic vagina for it to stay healthy. When you lose the estrogen, you lose your acidity. So that's why you're seeing more urinary tract infections. Intimacy, penetration, we can come very dry, very painful. Usually by the time women see me, they're like, I haven't had sex in 8 years. I just thought it was me. Like they have no idea it's because of hormones. So interstitial cystitis, moving on to that, is a basically chronic incurable disease that is probably inflammatory in nature. There's no blood test for it. Most bladders look normal when you scope them. And a lot of women will, I think, and a lot of urologists think, they're improperly diagnosed with it. So they come in and they complain to their doctor about recurrent UTIs or pain when they pee. Maybe they've never gotten a pelvic exam. They'll complain of some sort of pain down there without a physical exam, without somebody who knows what's going on. And they'll just be given this diagnosis of interstitial cystitis, usually followed by a list of foods to avoid. With the idea of something in some of these foods is irritating to the bladder lining. So I tell people I usually take more diagnoses of IC away than give it. Because again, IC is a diagnosis of exclusion. And then GSM is 50 to 80% of women. Right. So it's like, isn't that way more and so many women are like, my IC went away when I got on vaginal estrogen. And I'm like, that means you probably didn't have IC in the first place. You probably had low hormones that were improved by giving yourself hormones. So does IC exist? Is it real? Yes. Do most people who've been told they have IC? Probably not. Right. That's probably something else, like tight muscles, right? Like hypertonic pelvic floor, that can cause pain. If you don't get a good pelvic exam, they're just going to call that IC, and then a woman's going to suffer because she doesn't actually get the right treatment. So
something I'm interested in is the vaginal estrogen protective of the microbiome?
Yes.
In the vagina. Is that what the mechanism is there?
That's right. Yep. So vaginal estrogen, lactobacillus loves estrogen. Right. So lactobacillus dies off when it doesn't have estrogen. So you put the estrogen back, lactobacillus comes back. Lactobacillus creates lactic acid. That's what acidifies the vagina. And that E. coli hates that. Like the poop bugs hate an acid environment. So it's literally working to protect the backside from going into from the sewer system to, go crossing the playground. Sure. The other interesting thing, which is very early, a couple of years ago, nobody thought microbiome was important, right? And now in the WHI, one of the good things that came out of the WHI, women who were on hormones had a 30% decreased risk of colon cancer. Wow. Why? Why would being on estrogen decrease your risk of colon cancer? The thought now is people who are on hormones actually have a different microbiome in their gut than people who aren't on hormones, or people who, lose their hormones naturally and don't replace it. To the point of women's gut microbiome start looking like a male microbiome, and men have more colon cancer. And so we still need like, I'm not the world's expert on that, but we have at least 2 studies showing being on, again, systemic, not the local vaginal hormones. Systemic hormones, actually, your microbiome is different. That's probably why those people have 30% decreased risk of colon cancer.
I think that's fascinating. And I think that there's a new frontier in medicine that will open up once we start understanding the microbiome better.
Yeah.
And the fact that it's not just in your gut. I think people probably don't know that there's a vaginal microbiome. Yeah. There's a microbiome in your mouth covering your skin. It's almost like the system was designed well.
Yeah. Right? Yeah, exactly. I say this like there's a GIF, and it's like, when you think of sleeping with somebody, when a woman thinks of sleeping with somebody, think, is this person worth disrupting my microbiome over?
Yeah. I think that should be question number 1.
Right? Like,
definitely. Yeah, it's a good question. All right, so I got to move us on. Again, I want to read this question out because I think there's a lot of important details here. So we had this submitted as a DM on social. When I have a full bladder and there's no bathroom in sight, I squeeze my pelvic floor to keep it all in, but in doing so, I get a small orgasm, and then it's impossible not to leak. What can I do about it? And the caveat to that is she sent the question because she was too afraid or uncomfortable to ask her male urologist.
Yeah,
so I think that's a really important detail there.
Fair enough. Yeah, that's a problem because 90% of urologists are male.
Right.
But I mean, truthfully, I think any gendered urologist would be like, dude, why are you holding your bladder so much? Like, just don't do it in the first place.
Yes.
It's like, if you can give, like, the classic one is at the gym. There's for people who don't know, there's certain gym equipment that when used by some people will give you an orgasm.
Right.
People are now going to be like, Jeremy, can she please elaborate?
Yeah. Have a takeaway from your episode.
And is the Vitality Collective going to have those pieces of equipment?
Maybe we will.
So pelvic floor, absolutely. Yes, you can. Yeah. You can cause orgasms. That's not she's not broken. Like, that's fine.
Right.
It's just that, dude, don't stress your pelvis out in the first place.
Yeah. I think that's such a valuable point, like bladder health in general. I think people don't realize, again, that this is an elastic system and we shouldn't be stressing it out. Yeah, don't stress it out.
I mean, I always joke because people, a woman will come in, she'll have recurrent UTIs, and she's like, what do I do the next time I get a UTI? And I'm like, why don't we talk about preventing it in the first place? It was like, just let me give it 2 steps ahead of you. And a lot of, you didn't grow up and go to 7th grade and learn how many times a day is the normal to pee, right? Mm-hmm. Like, nobody gets taught that. But normal while you're awake is about every 2 to 3 hours. So somewhere between 6 and 8 times a day, you should be peeing. We pee less than that because we're busy. Everything else is more interesting. We have cell phones. We have long movies. We built walls. All the unnatural things that make us hold our pee, right? Like, the world used to be our toilet, Jeremy.
Well, there are some advantages to the progress we've made.
And then we've created specific times and places to go pee. But it's like, especially if people are very well hydrated, God, you should be peeing 8 to 10 times a day. And if you're not, it can cause dysfunction long-term and urinary tract infections, all those things. So to me, I would just be like, the solution is to pee more. And if you literally can't pee more, there is an issue with that. Like, whatever the job that is, whatever you're doing,
change something.
Pee more.
Yeah. Is pelvic floor strength an issue here, do you think?
With a specific scenario?
Yeah.
I don't know. Like, she's held her bladder past the point of discomfort. So your bladder will signal an urgency normally around half bladder capacity. Normal bladder. Adult bladder capacity is about a half a liter, 500 milliliters. So about halfway full, it's going to tell you, hey, think about it. Right. And then you're able to consciously say, no, I'm in the middle of a presentation. I'm in the middle of a podcast. And then so that awareness of having to pee will go away. If you keep ignoring that for a while, like, then it can get very urgent, very uncomfortable, more prone to leakage, more prone to infection, all of that. So it's like, just pee more regularly. Sorry. It's like, Jeremy, how can I get the benefits of 8 hours of sleep without sleeping?
Yeah.
It's like,
but if I can't do that, how can I get it? Yeah. A lot of the answers here have been quite straightforward and things that people can do and can take control of.
100%. Yeah.
Yeah. And sometimes it is the simple thing.
Mm-hmm.
You know, how do I balance hormones that I have lost? Put hormones back.
Yeah.
Right.
Right. What works better than estrogen for replacing the estrogen I don't have? Nothing.
Yeah. Did you hear you ask that?
Yeah. Like,
Right.
you create that, you're a billionaire, right? Like,
Yes.
The body
exactly.
was designed with hormones in mind. You know, like we're literally designed, like our mitochondria functions better with hormones. I'm sorry if you don't like it. We have that in tons of animal studies. We've got it in, Petri dish studies. Like mitochondria function better, and so, and that's what's such a rub when they're like, you can only use testosterone for libido, is like, it literally makes your mitochondria function better. Like, so your sex life is the only way for you to get something your body naturally makes? Are you insane? Like, it's crazy.
Functioned systemically throughout your body.
It's crazy. I mean, the other thing that's crazy about testosterone for a hot sec for the men is, like, we have so much more data on testosterone in men. Like, low testosterone in men associated with diabetes, dementia, depression, hip fracture, right? Like, all of the things, strength. Why aren't we screening men for testosterone at age 50?
Right.
Like, do we just not care? Like, if you have a man with low testosterone and you give him his testosterone back, he has a less chance of having dementia.
Yeah.
Why aren't we screening for that? Dementia is incurable, devastating, right? It's like, it's in the whole world's mad. So, but the point is, that's why you have to advocate. Like, if a man goes to a doctor, he's age 50 and he's like, I'd like my testosterone checked, and your doctor doesn't check a lab, like, come on.
Right.
It's such low hanging fruit. Just check a lab and see what it says,
Right.
So again, another one of the advocacy things I'm working on is don't even get me started about women and checking hormones, because it's like, we should probably do that too. But I think at least for men, 20% of men have low testosterone. Like, why aren't we screening for this?
Right.
Because there's no money. There's no money to be made in it, right? Like,
exactly. Yeah.
It's such low hanging fruit.
So, as we wrap up here, Kelly, what are 3 takeaways that if people just do this, we're going to start moving in the right direction?
Stop drinking alcohol. Prioritize flexibility and mobility. And you're 3, and then use more lube. That's always the right answer.
Great takeaways. Well, I can't emphasize again enough. Go and watch M Factor. It's such a deep dive into this. Follow Dr. Kelly on social and on her podcast. Where can they find you on those?
So on Instagram, I like to hang out on Instagram. I'm Kelly Casperson MD. On Instagram, the website is kellycaspersonmd.com. The podcast and the book are called You Are Not Broken.
Outstanding. Well, thank you so much. We might have to break this one into 2 episodes. We will have you back to do 100 more.
I look forward to working with you again. I think there's a lot of work to be done.
I think so too. Kelly, thank you so much.
My pleasure. Thank you.
That was an incredible conversation with Dr. Kelly Casperson on the realities of menopause, hormones, and how women can take charge of their health. There's so much misinformation out there, and today we set the record straight. Here are the top 3 takeaways from this episode. Number 1, hormones are essential for long-term health, not just symptom relief. We've been taught to fear hormone replacement therapy, but research shows it can prevent osteoporosis, diabetes, and even cognitive decline. If managed correctly, it's a powerful tool for healthy aging. Number 2, strength training is non-negotiable. It's not just about looking fit on the outside. It's about maintaining bone density, muscle mass, and overall independence as you age. Lifting weights at least 3 times a week is one of the best things you can do for your long-term health. Number 3, You must advocate for yourself in the healthcare system. Before making an appointment, research providers who specialize in hormone therapy and come prepared to ask the right questions. At Vitality Collective, we focus on proactive strategies for men and women to help you perform, feel, and age at your best. Visit us at www.vitality-collective.com to learn more. And if you found this episode valuable, share it with a friend who needs this information. Thanks for tuning in, and we'll see you next time. The information provided in this podcast is for educational and informational purposes only, and is not intended as medical advice. Always seek the advice of your physician or another qualified healthcare provider with any questions that you may have regarding a medical condition, treatment options, or before making any changes to your healthcare routine. Never disregard professional medical advice or delay seeking treatment based on something you heard on this podcast. Reliance on any information provided by this podcast is solely at your own risk.